Hello, I'm Matthew Weinstock, Senior Editor for Hospitals and Health Networks. Thanks for joining us at H&HN Daily's videocast series. As you know, healthcare is moving through a great transformation, from a fee-for-service model to one that's based on value, outcomes, and quality. Payers at both the private and government side are moving forward with plans for value-based purchasing, putting some pressures on hospitals and health systems. I'm joined today by Paul Roscoe, CEO of Crimson, a division of the advisory board, to talk a little bit about these changes in healthcare and what he's seeing in the hospital field. Paul, thanks for joining me.
Thanks, Matthew.
So let's talk a little bit about the transformation we're going through from fee-for-service to value. What kind of pressures is that putting on hospitals in terms of just data collection and understanding data and communicating with their doctors?
Well, the key, we think, based on our experience, is how do you align yourself to have a dialogue with a physician around improving their performance and quality and cost. What we think at Crimson that one of the key elements of driving that conversation is being able to engage one-on-one with a physician, with a group of physicians, and have a dialogue about how they can improve performance, both from a quality and cost perspective. Today, that's been very challenging for many organizations. There's been a lot of data that's been captured. Frankly, there's been a lot of data that's been published in various different public settings, but it's been very difficult to have a meaningful dialogue with a physician in a way that can engage them for change.
And is there an example that comes to mind where you've seen a health system really be able to use that data to drive performance?
Yeah, a great example from our membership is a hospital, Danbury Hospital in Connecticut, who are one of the sort of leading figures around CPOE, had done a lot of work historically with creation of order sets and evidence-based medicine, but they themselves still felt there was room for improvement. So they spotlighted about 8 DRGs that they thought there was a chance for them to really sort of bend the curve a little bit, and used Crimson to drive a spotlight onto those 8 DRGs. One of them, for example, is in the cardiac services area, where they felt there was opportunity to reduce the utilization of echo on patients. And they used our technology to compare outcomes and ultimately drove that utilization down to a specific target level they created. When they looked at the cost savings, the ROI, the hard ROI for those 8 DRGs, they felt there was north of $2 million in savings that they'd been able to achieve. And when they looked at it on a more broad scale across the whole network, they felt there was about $6 million of savings. So that's meaningful dollars. Another organization I would reference for you is Robert Wood Johnson University Hospital. They decided, rather than try and do this necessarily across the whole medical population, to identify 50 outliers, quote unquote, of physicians. They were able to put the spotlight again on those physicians, engage those physicians in a dialogue, look at areas for opportunities for improvement around length of stay, or around other cost measures, and maybe even around readmissions. And again, had a very compelling ROI from that initiative.
So as we move, though, to a clinical integration model, are you seeing commonalities in leadership at these institutions, Danbury, Robert Wood Johnson, that is driving that change?
What we're seeing is very strong physician champions that are going out of the gate and having dialogue. CMO at both of those organizations I reference are very strong physician leaders and champions for driving those performance improvement. That's for their employed physicians. As we look at clinical integration networks, we have a number of our members now that are 2 or 3 years into a formal clinical integration program. And now for independent physicians, the challenge becomes, in some ways, a lot more difficult. You've still got to capture data, but now you've got to capture it from various different ambulatory systems that exist. Some of these are very small practices. And so this is where technology, I think, really has a real opportunity to help capture data, present it in a meaningful way, engage the physician in a one-on-one dialogue, measure, and then incent. Pay them bonuses or other initiatives that you put into that that will drive that improvement.
Let's talk a little bit about accountable care. We know that the ACO model that CMS put forward wasn't very well received in the field. What are you hearing from your hospital partners and in terms of that CMS regulation and what they may be doing outside of that?
Well, I think organizations, regardless of their sort of ambitions to be an ACO or not, as the case may be, have a view that there has to be, because of the reimbursement landscape, who knows now what will happen given the debt debacle in the country as well, there has to be a wholesale systematic improvement to reduce costs in the business. We hear our members talk about having to take 15 to 20% of their cost structure out which is a huge amount. And one of the ways that they are looking to do that is to help drive physician improvement from a cost perspective and not trade that off from a quality perspective. So what we see them really is sort of putting a foot in each canoe, so to speak, fee-for-service world, but also thinking about those steps that they need to make to become comfortable in a value-based care environment. One of those is how to think about managing populations as opposed to just managing individual patients. And what we find a lot of our members now starting to think about is how do they start to capture data, how do they think more like a payer, how do they look at more actuarial data that allows them to benchmark their population against given indices, stratify the risk, and then using care management, how do they be much more proactive in addressing those populations, particularly those chronic populations. Wouldn't it be great if we could start to identify certain indicators that are important for you to be proactively addressing so that they don't become a readmission or they don't get seen in the ED a week later? That's when we can start to drive improvement. Technology has a large part to play in that.
Thanks for your time, Paul.
Pleasure. Thank you.
I'm Matthew Weinstock, Senior Editor for Hospitals and Health Networks, and be sure to check out the rest of our videos at hhnmag.com. Thank you.